to those. So Dr. Ibrahim Elsharkawi will be presenting on the nutrition and growth in primary mitochondrial disease. So I'll turn it over to you when you're ready.
Thank you. Let me just share my screen here. Can you see my screen okay?
Yes, that looks great.
Wonderful. All right. Okay, so thank you all for having me. My name is Ibrahim Elsharkawi. I go by Ibi as well. I'm a pediatrician and medical geneticist at Mount Sinai in New York City. So I think this is a good time to this is a good talk to follow Dr. Khan's excellent talk just now. I have nothing to disclose, and the objectives of this talk are straightforward. I'll be talking about how nutrition and growth may be affected in patients with primary mitochondrial diseases, and provide an overview on when and why to get a G-tube. So food and mitochondria. So as we very clearly just saw from prior talks, mitochondria, in summary, in its simplest form, mitochondria generate energy from the food we consume, from this sugar in the form of glucose, from fatty acids, from protein. The different hormones that get stimulated in response to different foods we eat or don't eat, such as insulin or glucagon, also have an overall effect on mitochondrial bioenergetics. So we know that food and mitochondria are closely related and very important together. Of course, there isn't a mito-specific diet. Specific diets may be indicated in certain conditions. So in the ketogenic diet in pyruvate dehydrogenase complex deficiency, for example, that is a well-known one, or ketogenic diet in mitochondrial epilepsies, for example. But for the most part, there are studies. This has been looked at and investigated, and it is an active area of ongoing investigation. But for the most part, there isn't one clear set of guidelines or consensus on what diet works, what type of diet or what macronutrient or micronutrient might work best. There isn't a one-size-fits-all, if you will. And studies have shown, like I said, many studies have looked at this extensively, but studies have shown conflicting results. For example, studies may show that in animal models of mitochondrial disease, a specific type of dietary manipulation may be of benefit, but we don't see that when we try to replicate that same dietary manipulation in human patients. And that's probably because the ATP needs, the overall ATP needs and bioenergetic demands of an animal model is very different to that of a human being. Or, for example, we might see one study in humans that show benefit to optimizing fat intake, dietary fat intake in patients with mitochondrial disease, and another study that may show detriment to a high-fat diet in patients with mitochondrial disease. And that's probably because there is a nuance between optimizing fat intake in a patient who's not getting enough fat to begin with to meet their daily demands, and just a high-fat diet per se. And there's probably also nuances and differences in the type of mitochondrial disease you have and how that influences bioenergetics and reactive oxygen species and so on. So that's why there isn't a one-size-fits-all. But the bottom line is something we can all agree on, as we just saw from Dr. Khan's talk, is optimizing nutrition and growth to the extent possible is important. So what are malnutrition and failure to thrive? So malnutrition is defined as deficiencies, excesses, or imbalances in a person's intake of energy or nutrients. So there are published criteria to assess malnutrition in a patient, in an adult or in a pediatric patient. And these are put forth by the American Academy of Nutrition and Dietetics and also the American Society for Parenteral and Enteral Nutrition. So in one single center study at CHOP, where I had the great privilege of doing my mitochondrial medicine fellowship, as Dr. Khan also mentioned in his talk, 26.7%, so just over a quarter of patients with primary mitochondrial disease had malnutrition. And then even though in those who didn't meet criteria for malnutrition, approximately 50%, close to 50% of both the adults and children consumed less than 75% of their predicted daily kcal needs. So quite a large number on all counts. And then failure to thrive, which is an archaic term, and that's why I put it in quotation marks above. We don't like to use these terminologies anymore, but you will still see it used in the literature or in medical contexts, but different semantics like lack of appropriate weight gain, we generally feel is a more appropriate description. But failure to thrive or lack of appropriate weight gain is defined as weight lower than the 5th percentile on a growth chart for age when compared to when compared to sex and age matched peers, or a change in weight that has crossed down 2 major percentile lines over a 3 to 6 month period. And we'll see an example of what a growth chart looks like in a minute. And this can result from inadequate caloric intake, increased caloric loss or malabsorption, or increased systemic caloric demand, or a combination of all. So this is what a pediatric growth chart will look like. We plotted based on the values based on age in months and years. And we have separate ones for girls and boys. We have ones for we look at head circumference, for length, and for weight. And generally, this is a nice growth curve here, growing nicely along the curve or around the 50th percentile. This is one example of ideal growth. Ideal growth can look like many different things. It doesn't have to be in the 50th percentile. A lot of the time, providers will be happy if they're growing nicely on their own curve. And it's worth noting that we don't have specific growth curves for mitochondrial diseases, but other types of genetic conditions, like Down syndrome, for example, have their own growth curves to recognize how different growth can be in one patient population compared with typical peers. In mitochondrial disease, there are many reasons for why someone might have suboptimal nutrition or malnutrition, or not eating or drinking to meet their daily demands. Some of these reasons are dysphagia, difficulty swallowing, gastroparesis, which is delayed gastric emptying, diminished appetite, which can arise from many different reasons, can be multifactorial. In patients with single large-scale mitochondrial deletion in particular, you might get pancreatic insufficiency, which impairs absorption. Food-related anxiety or behavioral challenges is something I always have in the back of my mind with any patient. Eating disorders or picky eating or disordered eating can happen to the best of us, and it's not something that often it's not something that we can control, but it is something that we all have to consider and think about and watch out for. Medication side effects, of course, can impair appetite or change our relationship with food and how we eat. Excessive metabolic demands, so patients in heart failure, patients with cardiac disease will need more calories and more specific macro and micronutrients than someone without the same disease state. And then on top of that, certain disease states call for certain dietary requirements or adjustments, may make eating even more nuanced and challenging than it already is. For example, if you have diabetes, you'll have to watch your carbohydrate intake. If you have chronic kidney disease, you might have to watch your protein intake, and so on and so forth. The consequences of suboptimal nutrition and growth, why we should all care about a patient who has malnutrition or who has lack of appropriate weight gain, is because it can lead to increase what we call morbidity, disease burden, or mortality, deaths. So it can predispose to infection, it can cause dehydration, it can cause a lot of worsening symptoms that patients with mitochondrial disease already experience to a high degree at a daily level anyway, like fatigue, dizziness, headaches. Something can happen called refeeding syndrome, where after a long period of not meeting your body's caloric needs, introducing refeeding all of a sudden or too quickly may cause electrolyte imbalance, and electrolyte imbalance that leads to organ dysfunction. So many reasons why we should all care about suboptimal nutrition and growth. Assessing nutritional status is not just a one thing that we do. We look at many different parameters. So in children, we review growth charts. In adults, we look at weight, height, BMI, muscle mass. Review electrolytes. We look at glucose or hemoglobin A1C, cholesterol, a lipid panel, which of course are part of standard guidelines, annual surveillance guidelines for patients with mitochondrial disease anyway. We look at vitamin levels, vitamin D, vitamin B12, iron levels, and so on, and any other labs as well. Often it includes a dietary recall, reviewing what a patient or a person eats on a daily basis. we look at macronutrients, so your fat, carbohydrate, protein, in terms of grams per day, in terms of as compared to what is recommended, RDA, recommended daily allowance for someone of that age and sex and weight and so on. And micronutrients as well, all the vitamins and minerals and so on that go into a healthy, balanced diet. And so, like we talked about, malnutrition has a specific definition that we attribute. We say someone has malnutrition if they meet certain criteria. But not having malnutrition, as we saw from the CHOP paper, does not mean that you're not on your way there, that you are meeting. Not having malnutrition doesn't mean that you are meeting your daily kcal requirements. So a G-tube. So often in cases where we have malnutrition or lack of appropriate weight gain, or where we just can't take enough food and water and so on by mouth over a long period of time, if it's sustained, we recommend a G-tube, a gastrostomy tube. So a G-tube or a G-button is recommended. Here is an example of it. It's essentially a tube that connects the outer part of our body, outer part of our abdomen to our stomach. And it's a way of providing liquid food and nutrients when you cannot get the amount you need from eating and drinking by mouth. It's inserted through the stomach. It is a surgical procedure, and it can be, and it is a surgical procedure. Here is another example. This is an example of what it might look like on the outside. I get a lot of pushback often from a lot of my patients. A lot of the time, and it's very understandable, right? It's very understandable that families don't want to over-medicalize their child. The idea of a G-tube, I always say the idea of a G-tube is a lot scarier than the reality of it in most cases. And of course, it does sound scary, but getting a G-tube itself is relatively straightforward. There's always an anesthesia or sedation risk, but we have to balance that out with the potential benefit of optimizing nutrition, which is large. You know, there's a great deal of benefit to optimizing nutrition. And something I always tell my patients and families is we don't want to wait until we're in crisis to get a G-tube, because if we're going to need, if we wait till we're sicker and more deconditioned, then the risk of going under anesthesia and sedation is even greater at that time. So we want to get a G-tube when we need it, when it's indicated, but before we're in a crisis where we absolutely need one. In an emergent or urgent situation. And then things I tell my patients, having a G-tube doesn't mean you cannot eat and drink by mouth. You can use the G-tube as much or as little as you need it, but it can always be there in case you need it or in cases of an emergency. And then having a G-tube also doesn't have to mean forever. And in the same study done at CHOP, 9% of adults and 16% of children with primary mitochondrial disease had a G-tube. So I think this is a fascinating area of active investigation. There's a lot of growing evidence that dietary manipulation may influence outcomes in bioenergetics. Some results are conflicting, and results in animal models, like we talked about, may not be the same as in human beings. We need to learn more about how specific dietary interventions may change outcomes in patients with PMDs and primary mitochondrial disease. And at present, in my metabolism clinic, I have excellent metabolic dietitians who see my patients with urea cycle defects, my patients with PKU routinely. But metabolic dietitians don't routinely see patients with primary mitochondrial disease, but maybe they should. And I say this, and I have to say, even though I would love for metabolic dietitians to see all my patients with mitochondrial disease, I also have to recognize that I really do think metabolic dietitians are unsung heroes. They have a lot on their plate and a huge work burden as it is. So I do want to be mindful of that as well. So these are some excellent papers I read as I thought about this more and prepared about this more. For anyone interested in reading more about this very fascinating area of investigation, these are some excellent papers right here. And thank you.
Great. Thank you so much.